Welcome back to part 2 of the brain tumor MRI protocol. In part 1, we covered the theory and medical conditions of brain tumor imaging, the trade-offs between resolution, SNR, and scan time, and why resolution takes priority for tumor imaging. We then planned all 5 pre-contrast sequences, the 3 𝗕-𝗵𝗺, T2 axial, FLAIR, diffusion-weighted imaging, and T2 star. Now in part 2, we're ready to inject contrast, plan our post-contrast sequences, and review all the images to understand what we're looking for diagnostically. So let's continue where we left off. We've already planned everything that's supposed to run pre-contrast, so after we run our diffusion and our T2 star, we are ready to do the contrast injection. Let's quickly recap all the steps we perform in this workflow. Before any scanning happens, we'll insert a cannula into the patient's arm, which serves as the injection point for the contrast agent. Once the cannula is in place, we position the patient at the scanner's isocenter with the head centered in the coil. The patient will stay at this position while we acquire all of our pre-contrast sequences. While those sequences are running, we also plan and set up all of our post-contrast sequences so they're ready to go immediately after injection. Once all pre-contrast sequences finish, we will inject the contrast. For manual injection, we slide the patient table out of the bore so we can physically access the cannula. This is when we enter the scan room with our prepared syringe. We inject the contrast slowly through the cannula with a steady hand. We also remind the patient to keep still and that the exam is almost over. Just 10 minutes left. Once the injection is complete, we press the isocenter button on the scanner. This automatically returns the patient to the exact same position they were in during the pre-contrast sequences. This is critical because we need identical positioning to compare pre-contrast and post-contrast images. Finally, we return to the control room and start our post-contrast acquisitions. The key is to have everything set up and ready, so we waste no time between injection and imaging. For protocols using automated power injectors, the workflow is simpler. The patient stays at isocenter the entire time, and we inject contrast remotely from the control room. But for manual injection, like we're demonstrating today, pulling the patient out and using the isocenter button ensures perfect repositioning. We have already done steps 1 to 3. So now we'll start with step 4. Plan our post-contrast sequences. Again, we should always use the same slice planning pre and post so that we can compare the images. So I'll double-click to open each sequence, right-click on its pre-contrast equivalent, and copy all slice planning. Now that we have copied the 𝗵𝗵𝗺, I'll do the same with the axial T1. Finally, we have the coronal, which hasn't been previously acquired. You can acquire a coronal pre-contrast if you want a baseline, but you don't need to. We can also get the coronal in a different way. Remember, the very first sequence we acquired is a 3D, and we can reformat the 3D into coronal, axial, and sagittal as many times as we want. So we could reformat this sequence and make a coronal out of it. But we're going to do the post-contrast coronal without any pre-contrast equivalent. As you can see, this sequence is already planned. The most important thing to know is that the midline needs to be perpendicular to the mid-sagittal line of the brain. We must cover from the posterior sulci to the frontal lobe without cutting out any anatomy. If you think it's too tight here, you can expand 1 extra slice. This will be right-left most of the time because head-foot is going to give you massive wraparound and won't allow the smallest field of view. Again, we use thinner resolution here, so make sure you're covering the full anatomy. We're doing a T1, so we'll use the same TE and TR as we did with the axial. We'll keep the number of excitations to 3. You can increase it if you want, or decrease to save time, but keep in mind that fewer excitations will lower your SNR, and we need to keep our SNR strong to visualize small lesions. Now these last 2 sequences both use 𝗲𝗊, a parallel imaging technique with an acceleration factor of 2. Both also use fat suppression. If you look at the sequence name over here, FS stands for fat suppression, and it's applied spectrally. So this is our last planning. The simulator is currently running the baseline of the T2 star. Once that's done, we're ready to inject contrast. We've now finished our acquisition. Keep in mind, I'm not reviewing anything yet because we're going to do the review later. I'm just making sure to review each image as they're acquired to ensure my patient doesn't move, isn't uncomfortable, and doesn't need coaching on my side or talking to them. We're going to review with more detail later. But let's carry on with the injection of contrast. We'll choose a standard concentration, which is 0.5 millimole per milliliter, which is deemed standard practice. We can inject up to 15 to 20 milliliters, depending on the weight of the patient. In this case, 15 milliliters is enough because the patient weighs 80 kilos. This equals 0.1 millimole per kilogram for a patient of this weight. We'll start acquiring 5 minutes after contrast injection to let the contrast spread into the tissue and blood vessels signal fade. Check what timing is optimal within your clinical practice, as it depends on the contrast agent used. Consider that 3D sequences take from 5 to 6 minutes to acquire, and we're going to start with 𝗵𝗿 axial post contrast T1, which will last roughly 5 to 6 minutes. Actually, let's check. This is set up as a 10-minute scan, which is not ideal, so we definitely need to do some optimization. Let's go into the special tab and turn on GRAPPA parallel imaging. Now we're around 5 minutes. Again here as well, 6 minutes. Because we're around 6 minutes in acquisition time, I'm going to run the sequence 5 minutes after contrast injection, starting with the 3D 𝗵𝗿. Then we're going to run the other 2 and probably go up to 7 or 8 minutes to keep following the clearing of the contrast. Ideally, you want to acquire the axial immediately after the 3D completes, which is usually around 10 minutes post-injection. Then we want to acquire the T1 coronal around 13 to 15 minutes post-injection. Acquiring the T1 axial post-contrast at 10 to 12 minutes post-injection will provide peak parenchymal enhancement. Delaying the coronal a bit will still have excellent enhancement, and the fat suppression will help more than timing in this case to get a clearer picture. Just to summarize while this is scanning, we use standard gadolinium at 0.5 millimole per milliliter, then wait 5 minutes before starting the 3D 𝗵𝗿. By the time it completes, we're at around 10 minutes post-injection, which is ideal for peak parenchymal enhancement. Now, while we wait for the remaining sequences to acquire, we can start reviewing our pre-contrast images. I'm going to select the image viewer and pick up my first 3D sagittal 𝗵𝗿 pre-contrast from the bottom of my list. I'm going to start scrolling because here I want to look at the entire anatomy of the patient. This sequence is my baseline for anatomy. It will help me identify intrinsic T1 hyperintensity like hemorrhage, melanin, fat, and protein. All of these things that can be mixed in a tumor. There will also be mass effect and structural distortion around the mass area. The tumor tends to swell within the restricted space of the skull, which could cause ventricular compression or shift. In this case, the tumor is not touching the ventricle, but in another case, it could compress or shift the ventricles. So we want to describe the morphology of the mass, what we see, where it's compressing, and the relationship and possible infiltration paths. Next, we're going to review the T2 and the FLAIR. These two will show tumor composition. Specifically, the T2 will enable us to tell apart cystic and solid components. As you can see here, we have a nucleus, which is liquid hyperintensity on T2, and there's a capsule with lower intensity around it. So we can assess the internal architecture and what is edema. In this case, for example here, I can assume this is edema, and then there's infiltration over here, and then again something liquid over here, which could be edema or just a different consistency of the tumor. Let's see the FLAIR, which suppresses cerebrospinal fluid. If the signal doesn't suppress, it's tumor with different timing than cerebrospinal fluid, helping us see infiltrative margins and non-enhancing tumor extension. It still gives us an intuition of the periventricular situation, whether they're infiltrated within the ventricle or not. It also highlights lesions because it suppresses the cerebrospinal fluid. Let's now check the diffusion-weighted imaging and the ADC map. As you can see, we have the ADC map, the trace diffusion with b-value 1000, then b-value 0. We tend to get all three of them. Let's select the part where the tumor is visible. You can see the tumor over here. Let me highlight it quickly for you. In a healthy patient, we want to see high diffusion-weighted signal and low ADC. But in this case, we have low diffusion signal and high ADC, so it's the opposite. This indicates low cellularity, so something that's definitely not a high-grade glioma, and it's not a lymphoma. But determining the diagnosis will of course be up to the radiologist. In this case, where we have high ADC and low diffusion-weighted signal across the mass, we can say that diffusion is facilitated and not restricted. This could mean we're facing necrosis, cystic components, vasogenic edema, or something of that nature. Now we also have our post-contrast sequences ready, so I'm going to run them both while we review our 3D post-contrast. Ideally, you want to have two viewers side by side. Actually, we've gotten an error here because we acquired this in axial when we should have done sagittal, so most probably this one will need to be repeated. What I'm going to do is clone this sequence and run it again. Now this is very important. As you can see here, we also have some artifacts. The artifacts are going exactly onto the mass that we're supposed to be studying. So this is no good, and we would repeat the scan anyway. Also, we need comparison, and we can't compare an axial with a sagittal. We need to compare sagittal with sagittal. So we're going to redo this after these two have finished. But in the meantime, we can review it. We can see it's a bit artifacted, with noise and ghosting over here that disrupt our image, especially because they overlap with the tumor architecture. But you can see how the thin slices let us follow the mass continuously across slices. So as we scroll, we can see its full extension through multiple planes. Now, what do we expect to see from this T1 post-contrast 3D? Definitely some enhancement patterns in the tumor, which I can't see except for this middle region over here. These enhancement patterns are key to guiding diagnosis. For example, we look for rim enhancement, which appears to have a ring shape. This is usually typical for high-grade glioma, abscesses, and metastases. More homogeneous enhancement instead suggests we're facing a meningioma, lymphoma, or some metastases. No enhancement at all could indicate low-grade glioma, like in this case, or in rare cases, some high-grade gliomas also have no enhancement. Finally, nodular enhancement that appears like little nodes or spots suggests a complex cystic lesion or hemangioblastoma. What we want to look for in the image is if there's a dural tail, which is a tail of dura mater tissue that collects into spots. Then we may be facing a meningioma, a tumor that starts from the meninges. Metastasis, lymphoma, or infection may appear as multiple lesion spots all over the parenchyma. If there's enhancement in the cerebrospinal fluid, where it's supposed to be black, then we're facing something rare, which is leptomeningeal enhancement with cerebrospinal fluid involvement. There could also be rare instances where vascular encasement suggests higher grade meningioma. In the T2 star gradient echo, we want to look for blooming artifacts or the dual rim sign to confirm that we're seeing hemorrhage or cavernoma. If you have the ability to run a susceptibility image and you see susceptibility distortion, then it could be calcification or oligodendroglioma. So how do we know for certain? First, we can look at overlays side by side. That's why we acquired with identical spatial resolution and planning to better enable this comparison. Second, we'll compare the pre- and post-contrast images. An ideal approach is to get an MPR reconstruction of this 3D 𝗵𝗃 and then compare it with the post-contrast axial T1 or coronal T1. The simulator doesn't enable you to do MPR reconstruction, but you can right-click and download the image as a DICOM and then pop it into any third-party software to do the MPR reconstruction. You can also import the DICOM of the axial post-contrast T1 with fat saturation and the coronal as well to compare them in the third-party viewer. The viewer will probably also have some sync function to handle scroll syncing of the three images you put side by side. In this case though, we can see in our T1 that we have some enhancement, but not too much. We can be certain there's no fat composition because they're both fat saturated. Finally, we will look at the FLAIR to see the extent of the tumor, and to fully understand its composition, we should look at all the images side by side. So that's the entire brain tumor protocol from start to finish. While we wait for this last sequence to finish, let's go through the most important takeaways for brain tumor protocols. First, we generally prioritize resolution, then SNR, and lastly scan time. Resolution is critical because missing a 2 mm metastasis could change treatment decisions entirely. SNR, however, must be adequate to make images diagnostic. At 3 Tesla, we typically have enough SNR headroom for good resolution. But at 1.5 Tesla, it's especially important to not let SNR slip too much. Scan time comes last, but if the patient is uncooperative, it may become the main priority to avoid motion artifacts that can destroy even excellent resolution and SNR. 3 Tesla is also preferred for better SNR and contrast while keeping scan time short. Second, a multi-contrast approach is highly recommended. This means there's no single type of sequence that's sufficient. We need T1 pre- and post-contrast, T2, FLAIR, and diffusion-weighted imaging as minimum core sequences. This requires longer scan times, but it's justified for diagnostic accuracy. Always, always, always obtain very good pre-contrast T1 and choose 3D 𝗵𝗃 because it enables multiplanar reconstructions in different planes. If you fail to fat saturate at 3 Tesla, you can use STIR or inversion recovery instead of the spectral method. Also, when you image for surgical planning, metabolic profiling, or tumor grading, you may also need to add advanced techniques like perfusion, spectroscopy, or tractography. Third, the key diagnostic principles are the enhancement patterns, which enable us to differentiate between types of masses. FLAIR tells us the extent of infiltration of that tumor. If there's restricted diffusion, we can tell if it's a high cellularity tumor or an abscess. Perfusion or spectroscopy, when performed, can add information to grade that specific tumor. For example, if there's high-grade perfusion or metabolic deformation on spectroscopy. Fourth, make sure to avoid the common artifacts that can arise in brain tumor imaging, which include motion, susceptibility, chemical shift, wraparound, truncation, and geometric distortion in diffusion-weighted imaging. Some techniques we can use to avoid these artifacts are to use spin echo instead of gradient echo sequences, increase the bandwidth, activate fold-over suppression, increase the resolution, and use parallel imaging and short TE. Motion artifacts are the most important to control because brain tumor protocols take more time. We need to perform many sequences, and some sequences, like T2 and FLAIR, can be quite long. So make sure to coach the patient, comfort them while scanning, and immobilize the head as comfortably as possible. If needed, consider sedation. Finally, remember that definitive diagnosis requires careful evaluation of all multiparametric acquisitions, comparing with prior studies, and correlating with clinical presentation, like seizures, deficits, confusion, or movement difficulties. It's a multi-team evaluation. There will definitely be a neurosurgeon for surgical planning who will be involved in delivering the diagnosis to the patient. The key features to look for in the report of tumor scans are the tumor's size and location, the mass effect and shift on surrounding structures, cortical involvement, vascular proximity and involvement, typical enhancement characteristics, and any perfusion or diffusion findings. So that's all you need to know to perform a great brain tumor protocol. I hope you found it useful, and I look forward to seeing you in our next session.